introduction. My name is Syed Ehtisham Junaid. Many of you have actually come across some of our own previous courses for radiology seminars. Some of you guys I've worked with. I can see some of the names. I recognize some of the names, so I've worked with you guys in the past. So nice to see you. Thank you so much for joining. That's very nice to see. And we'll give people a couple of minutes. In the meantime, so the objective of today, what I've done with the help of some colleagues is got a few radiographs, which are quite important on in the sort of acute situation. A&E's acts of accident emergency for those who are joining outside the UK, casualty, ED, ER. So it's a mix of cases, and it's not a definitive list of the things that you shouldn't miss, but it's certain things you should look out for, because I think it'll make you, especially in the middle of the night, in the evenings when you don't necessarily have the radiologist around, so things to look out for. The way I'll do this is I'll show you a radiograph, and then what we can do is have a look at it with good detail. I'll give you a few seconds, and I know real life is not a few seconds, maybe say 15, 20 seconds. Have a look at it and see if you can formulate your diagnosis, and see if you can figure out what's going on. So don't get too disheartened if you don't see it on first attempt, because that's normal. I mean, I'm showing you this very, very quickly. So just want to acknowledge some of my colleagues. None of this is single-handed. Dr. Donna House, who I work with, she's an excellent radiologist, and also Dr. Imran Lasker, both of them very, very good radiologists who've helped with all this stuff. So, are you guys ready? Are you ready for this? Say yes, something like that. Come on. Ready for this kind of, come on. Okay. Very good, excellent. Let's go for it. So firstly, have a look at this. How many of you would miss this? I don't think many would miss this, right? You know, you've got the star there, great big fracture. So today I'm not going to be showing you stuff like this, right? So this stuff is so obvious that you don't even need the radiograph. Look at where the hand is going, right? So I think that somebody on the street will be able to tell you that this is not normal. However, let's have a look at this. How many of you would call this normal? I would certainly call this normal because I only have one view. Let's have a good look at this radiograph. There is a great, really obvious fracture. None of you would miss this. But that's the AP, and this is the oblique. So a very, very important learning point is don't discharge the patient if you've just got one view and you're suspicious of a fracture, right? One view is no view. You want more than one view. And this is, it's quite displaced. It's actually a spiral fracture. So, but on this one, I just cannot see it. No matter how hard you look at this, you will not see this fracture unless you do the oblique. And so it's really important that, a very important principle, get obliques, get laterals. A single view will catch you out. I was going to put a funny meme on, many of you have come across this funny meme where Prince Williams is showing three fingers. When you look in an AP projection, from a lateral projection, it shows like he's, giving the middle finger. And a few other ones going around. I didn't manage to find one of those, but, if you have got anything to do with radiology, you'll have seen that meme. Okay. So this is slightly more tricky. Okay, have a look at this. I'm going to give you a few seconds and then we'll talk about it. So I can see some answers, right? So it's probably nice. If some of you can type away answers, that'll be really good. It gives me an idea of, because we've got actually loads of people signed up. Unbelievable now. It was meant to be a very sort of short, friendly session for some people I'd known, but the word got out. So, and that's great. And as many people can learn from this, even better. So a lot of people are actually getting focused on here, right? and here, okay? But actually, if you look here, and I can see somebody's figured, there's a few people have, excellent, very good. Some people have actually seen this. So this patient actually got a fracture of the hamate. Similar mechanism as punching someone. In fact, you can see this guy's been punching somebody in the past. So this is not new. He's got a remodeling deformity of his fifth metacarpal. So he's obviously punched somebody in the past. He's done it again, or she's done it again, and you've got a fracture of the fifth. So although the patient may have similar history, but look all along the line of the force, and so this is exactly what's happened: a fracture of the fifth, or a fracture of the hamate. Okay, this is a classic. Have a look at this. I don't know why it's doing this. Right, so a lot of people are getting really excited about this. Getting really excited about this. Okay, I mean, you could get a little bit excited about that. I think there's probably something going on here. But is there something more serious in this? Anyone? I think somebody's got it. A few of you've got it. Okay. Look there. This patient sublux his. In fact, look at this, right? Can you see that? How the fourth and fifth metacarpals have really dropped. Yes, they're shorter, but there's got a drop. And this view, the carpal, the distal carpal row, you should see very, very clearly. We don't see it at all, which tells me that there's a fracture there. In fact, you should always, in 100% of people, you should see this joint very, very clearly. And if you don't see that, you get worried that you've got a fracture. In fact, this guy's fractured his hamate. Not only that, and subluxed the fourth and fifth metacarpals, because we should be seeing this joint just like that, but we're not seeing it. It's gone, and it's got this overlap, and so essentially it tends to sublux dorsally, and people will miss this, and it happens, and it's a significant injury. So look out for this, especially. I mean, look at the clues of how the metacarpals have suddenly dropped, and so. Exactly. So you should be seeing the sign. Somebody said light of day sign. That's very good, because what you should see is kind of the horizon over the hamate, but you don't see it. You just see kind of this mishmash of bones and overlapping, which you shouldn't see. It's an important injury. All right. So this is not an easy one. Have a look at this, and I've really zoomed out for you guys to help you, because I know in real life you don't have a few seconds to look at a radiograph, but have a look at this. So I can start getting some answers, so then I know, so it's kind of move on a little bit. Okay. So cavitate subluxation, all right. And in fact, just remember from the last case, the previous guy, you couldn't see this. In this one, you can. So I know that this is preserved. Now, this is not an easy one. I'm going to give it away pretty quickly, because this has an important learning point more than the actual fracture. And it's this, right? Trapezium to the thumb. Now, this is not an easy, this is a fracture there. This is not easy, and I appreciate that you wouldn't probably pick it up. And in fact, I'll show you the MRI, which has got edema and some, and then it had a sclerotic line. So it's definitely fractured. But the point I want to make here is that these patients will present with anatomical snuff box pain. In fact, this entire region will present with anatomical snuff box pain, an anatomical snuff box. And so it's not, everybody thinks, oh, it's a scaphoid, oh my God, scaphoid because it's anatomical snuff box. Actually, think here, base of fifth, ulnar styloid. These will all give you a snuff box pain. So look particularly hard, and you might even be able to palpate a little bit more. And obviously, if you're not sure, what do? splint them. In certain places, they may be able to MR them straight away, re-image in a few days, in a week, 10 days time. But the teaching point is that it's not just a scaphoid that gives you anatomical sniff box pain. This patient had those symptoms as well. Okay, so a slightly younger patient. We've got. So this is actually quite a straightforward one. So if you've done enough of X-rays, you'll see this is quite straightforward. You can see, is it acute or not? Is it acute? Anyone? Do you think anybody think it's acute? Okay, I mean, some people say acute. Did it happen? Yeah, so he's got a periosteal reaction going on. So it's not super acute. He hasn't just done it 5 minutes ago, or this child hasn't done it really. It is. You've got an effusion going on. What have we got? We've got that, the classical champagne glass is disrupted, right? And this patient's got a supracondylar fracture, typical, in pediatric patient population, where also there's a periosteal reaction going on. So that's another clue in any fracture, because often many patients may have a fracture a few days ago. So look out for the periosteal reaction. Now this tells you that this wasn't, a few minutes ago. This may have been a couple of days old. So it's given the body to have a kind of a periosteal reaction, which lays down a bit of ostium, which is hyperdense, which you see on the radiograph. But nonetheless, in fact, one of the really key thing with looking at radiographs, especially acute, is look at the soft tissues. Right? So look at soft tissues and look at the things around the bone. So periosteal reaction is very, very important. Soft tissues, is any joint diffusion, because if there isn't any of those, the likelihood of fracture is a lot lower. And I mean, sometimes I used to do A&E. Used to do A&E registrar before radiology, and in the middle of the night, and you see a radiograph, and you think, oh, is that a fracture? Is that not a fracture? And you start seeing lines. And so a friend of yours is the periosteal reaction, soft tissue density. If you see and any swelling, so they'll really, really help you. Right. A lot of people get stuck with this. They get really muddled up with this radiograph. Right. Any idea what's going on here? Any idea what we got here? Oh, nice. Nice to see somebody I know very well. Right. A lot of people saying good things. That's nice to hear. Right. So let's go through this systematically, right? So you've all heard of Critol. So let's label this properly, right? So what's going on? So capitellum. So in pediatric radiographs, for those who don't know, it's the ossification of the pediatric elbow. Now, a lot of people get really muddled and really kind of stressed out about, oh, when does C come in and when does don't worry about that. The important thing is the sequence of when they happen, right? So let's go through this, right? Critol. So C is the capitellum, R is the radial head. Okay, so they all look okay. Then the I, this is the internal, so this is the medial epicondyle. CRI, T is the trochlea, so the trochlea is there. O is the olecranon, right? So that leaves us with the L, which is the lateral epicondyle. Now, what do you think of this? What's going on there? So this really should be up here, right? What's happened is it's been pulled off. So, and it's quite typical. This is a kind of avulsion injury of a lateral epicondyle. But the important thing the teaching point here is, remember that the order of when they come, and so the lateral epicondyle is the last thing, and that's why it's the one which is the smallest here, and even on this image, it's the least ossified component, right? Critol, CRITOL. Oh, this is a bit of a fiendish one. Have a look at this. I enjoyed finding this radiograph. Some of you will find it anyway, because I can see some very, very, very good radiologists and people I know. Oh, someone's got it. I've actually given you a slightly easy one. This one was even more difficult. This patient had a radiograph which was done a few days prior to this, and it was very difficult to pick up. But whoever picked it up did a good job. So, but I thought it may not project that well on Zoom. But let's have a look, see how many people picked it up. So, some people are thinking about okay, good. So there's fat pad elevation. Good, that's very good. So the common thing in adults, right? The most common fracture is the radial head. Right, that's the most common fracture people get, radial head. But do not forget the coronite process, right? And in fact, this guy's got a fracture here. It's actually fairly easy to pick up now that because it is actually, you can see a loosened line. Initially, you couldn't see it very well, but nonetheless, look out for these. Sometimes you might see them on the lateral. They're just kind of sticking up. You see a fragment around the radial head here. So unless you look for them, you won't see them. And obviously, the patient's got a nice elevated fat pad, not as big as you might see because actually it was much bigger a couple of days ago. Nonetheless, look out for these. The other tip I want to give you with radial head fractures, if you don't see anything, but you see a great big effusion, treat it like a radial head fracture because they can be notoriously difficult to pick up, especially the undisplaced radial head fractures. And I would really urge you to really zoom in to the radial head because they'll be intra-articular and look on both sides, AP and lateral, to get a good view because they can be notoriously difficult to pick up radial head fractures. So if you don't, you palpate the radial head, it's painful, you see an effusion, but you can't see the fracture, just treat it as a fracture. And then you kind of refer to orthopedics, and then they can follow it up. Because if you miss them, they're often intra-articular, and then they can develop arthritis, they can get problems with their supination, pronation. So it's best to be sorted out. Okay. Have a look at this. Okay, people are saying different things, and I know why, because there's a little bit slightly confusing thing in this. So a lot of people are saying, okay, fine. This is an anterior dislocation. Now, why have I put an anterior dislocation is pretty easy to pick up. So why have I put, first, let's just look at the anatomy. Glenoid, articular surface, humeral head. They're very, very far apart. So this is an anterior dislocation. But this is real life, right? Patients will not give you a nice AP view. And they will definitely know somebody's asked for a Y view. If you've got a dislocated arm, which is really, really painful, there's no way. Well, you may even be able to get a little bit of a Y view, but definitely not an axial view. And so you've got to rely, if you can get another view, ideally, and get the best possible view, another view you can. In this patient, for some reason, I only was able to get, we only had one view, and this was it. But you can diagnose it simply on here because look at the two are not congruent at all. And this is not an AP, this is not a Y view, this is an X view. This is the best view that patient could produce. They're in pain. I think they had other problems, so they said, this is all I'm going to give you. Take it or leave it. This is what real life is about. But this is why it can be a little bit confusing. But actually, go back to basics, and you'll be able to hopefully make the diagnosis. So do not base the shoulder. In fact, I've seen patients who've come back with a shoulder dislocation, wasn't picked up, and then because they had some other injury, so distracting injury, they've had a dislocated shoulder, and then the shoulder view wasn't done great. You don't blame anybody; it's life, and so you just got to have your wits about. Okay, let's have a look. What are people saying? So these fractures on here. So this is a you can do different views. I've only shown you one view on purpose, and people get a bit confused with these. So the way to look at these ones, for example, is follow the line. So, you got the superior, I don't know what these lines are called now, I've forgotten the names, but you follow the lines and to make sure that there isn't any incongruence in any of these. By the way, just a quick thing before I forget to do this. So you'll get 1 CPD point for this whole session. So make sure you tune in to all of it to get 1 CPD credit. I should have mentioned in the beginning. Right. You can see this. A lot of people call this kind of the stool, right? And this is the elephant's trunk, and one's there, one's here, and one is here, right? Okay. So this can break anywhere. And let's see if we can follow the elephant's trunk on this side. Oh, what's happened there? So the elephant's trunk has bent, and so essentially you've got a fracture of the left zygomatic arch. So this is actually okay. This is all right. This is okay. So he's actually fractured there. So sometimes it can be subtle to pick up, and if you're not sure, get a CT. But often you will see them, probably because there's a lot of overlap, and sometimes patients can't move, and you don't necessarily get the best image. But don't forget other things. Don't forget the jaw, the mandible. You get a little view at the C1, C2. So do look out for that. If you the eyebrow sign, we get base of orbital floor fracture, so you get air leaking up. And I suspect even this guy. Sorry, excuse me. I wonder if something's gone wrong here because you've got a bit of opacification here as well. Maybe, but certainly, definitely, this is gone. Okay, this is a difficult one. So how do you get? If you just listen to the end, I'm sure you can see. You just got to give. I think you've got to give feedback. The RCR. One of the things that the RCR says, the course has to have. Well, it's not a course; it's just a kind of webinar. But if you've just got to have feedback attached to the end of it. Right. So let's see how many people can get this. We love this in radiology. There's a term for this in radiology. It's called satisfaction of search. I think somebody's got it. So this is, I'm sure most of you will have picked this up, right? There. And the open mouth view, the PEG view, is not for the PEG. What is it for? It's really for the C. It's essentially lining up the lateral masses view. It's essentially for C1 because if the lateral masses of C1, C2 don't line up, you're worried that the patient's got a C1 fracture. And yes, you can pick up C2 fractures, but how many of you will pick up a fracture here? You can't. It's just too much artifact. And then it's very difficult to pick up PEG fractures on an open mouth. I personally find it very difficult because there's so much artifact. But there is, however, a loosened lesion in the patient's jaw. And in fact, this patient, if I show you the CT, what's the diagnosis for this patient? It's myeloma. So this patient actually had myeloma. So they had myeloma, had a fall. So they've got a pathological fracture through C1. But actually, so this is actually a myelomatous deposit. You can't diagnose myeloma just by looking at that loosened lesion. It can be anything. There's an entire differential of loosened jaw lesions. But the important thing is satisfaction of search. Just because you've got a patient who's coming acutely into A&E and you see, you diagnose a fracture, but sometimes there's something more important. You're hoping that the radiologist who reports it later on will pick up, but I think for your own personal satisfaction, and if you are the radiologist doing the radiographs, don't let this bite you, because it has got big teeth. If you're a radiologist, it will bite. Okay, so this patient went on to have a CT and it went on to have that. Okay. What have we got here? Yeah, it's a good multiple myeloma, METs, whatever. Good, excellent. If I'm doing this too quick, too fast, am I not doing it right? Give me feedback so I can see, because obviously, normally I'm used to lecturing people in a lecture theater and or seminars or tutorials, so we can see people's faces. And but now all I'm doing is staring at the camera and the screen, and I'm the only one in my department right now. So if it's going okay, let me know. Fine. So very good. So people have picked something's not right here, right? People guessing something's not right here. So this is 2, this is 1, 2, 3, 4, 5, 6. I'm not going to go 6, and then this is 7. I'm not going to label you how to report to C-spine. In fact, I've done an entire session, I think 8 or 9, 6 or 7 sessions online on C-spine CT. It's on our Facebook page. But essentially, the main thing is, look at this. Look at that soft tissue. It's just way too much. Look at the soft tissues, way too much here. And the edges of this don't look great. If I told you this patient was septic, what would we be thinking, right? Because we're thinking of abscess, but what's happened to this disc? This disc has disappeared, and you've got a kind of a wedge deformity, a kyphotic deformity. This patient actually has discitis, right? So you can see that there. Let's go back here. You can see how this is 7 and this is 6. If I draw the outlines of 6 and outlines of 7, right? How it's essentially the infection is eaten into. This is spondylodiscitis. And here's the MRI of this patient, where the disc has disappeared. This is a T2 weighted image, where the disc is gone. You can see this is C6, this is C7, and you've got all this extra prevertebral infection as well, right? People are saying TB. This is not typical of TB, but yes, it could be TB. TB doesn't tend to be as focused around the disc versus, but TB would be on a differential, but this is not typical of TB. This is bacterial discitis, spondylodiscitis, right? So you're in A&E, you've got an acute patient here, right? They're involved in trauma, they're very unwell. Patient gets intubated, has lots of lines, has a chest drain put in. What's going on? Real life. Right, okay, fine. Surgical emphysema, no points for that. It's not really, really obvious. Okay, pneumomediastinum, right. There is a bit of pneumomediastinum. Very good. Anything else? Yes, somebody said it. COVID. This guy has got COVID. So, you come, unfortunately, he has got COVID. But what's really, really important, what do you need to do? Very good, exactly. The ET tube is in the right main bronchus. Look, if I can draw that, the carina for you there. Right, that's what it's doing. Is going into he hasn't collapsed his lungs yet, his right lung or his right upper lobe, but it wouldn't take much. Maybe it's just because the bezel of the thing is facing such that it's saving him. Not the right lung, pardon me, the left lung. It would collapse the left lung because obviously you'd stop aerating it. But it wouldn't be far. So it's important. Yes, the ET tube is misplaced. He's actually got another. This is not an easy one. You'll have to zoom in. I'll see if I can zoom in for you. He's actually also got a pneumothorax as well. Very small pneumothorax. That can happen from ventilation. But I wouldn't expect you to pick that up. But the important thing is the lines. The lines going the wrong way. And the thing is, because he hasn't collapsed his lung yet, because typically the classical, school teaching is, the ET tube is in the wrong lung, going into the bronchus, and the other lung becomes collapsed and white out. But this is, so you don't necessarily look out for that, but really, really important. Okay. And I've zoomed in for you. So there's a little pneumothorax. Okay. But that's fine. And also the ET tube is the wrong way. Okay. If you've got a good size, if you've got a normal size screen, you'll be able to see this pretty straightforward. Right? You should be able to see this. Right, pleural effusions, yeah, you don't get many marks for that, sorry. No marks for pleural effusions. That'll be too easy. Someone's got it. No, come on. This is a real A&E X-ray. Oh, they're all on. None of these are fake. These are not computer-generated X-rays. These are all real. Right, right. So people are starting to get it. People are starting to get it. Compare this side with this side, because your eyes are being drawn here, but you need to look up there, right? This patient's got a right pneumothorax, and yes, you do not see the nice nice lung edge because it's right behind the ribs. So you don't see it. But what you do see is loss of lung markings. So you can see lung markings here. You don't see them there, right? Don't just fixate on the and I think he's got a rib fracture as well. But the important thing is pneumothorax. Okay, easy one. Nice and easy. What would you do with this patient? Patient's got some pleuritic chest pain. Anyone? Yeah, paratracheal, pneumothorax. This is actually a normal case. This is not a pneumothorax. This is a skin fold, right? This is a skin fold. This is not a pneumothorax. Why is this not a pneumothorax? Every loosened line does not. Look, you've got lung markings on both sides. Okay, there. So there's not a pneumothorax. This is a skin fold, and it can make you think like it's a pneumothorax. And in fact, you can even get them in kids in the abdomen when you start doing for the neonates, and then the skin folds and things. You start thinking, has the patient has a pediatric case got pneumoperitoneum? So skin folds, and especially in kids, they're very common in kids, right? Skin fold, not a pneumothorax. So don't go around sticking chest drains and things in these people. Okay, so we are heading south now. So we've gone from the neck, chest. Now we're heading south. I don't. There was no. So if somebody's saying right paratracheal widening, I don't think there was any. Right. So this sort of case happens all the time. These patients get sent home because you fixate on something else. Your eyes make things up. Like you start making things up. Like, is there a fracture here, or is there a fracture there, or is there a fracture here? But actually, there's a fracture there. This is a calcaneal stress fracture. Fairly common. Typical patient is postmenopausal females, but also people who do a lot of running, especially females who are very, very active. So this is a calcaneal stress fracture. You can easily walk past this, radiologist or non-radiologist, simply because it's not displaced very well. All you see is a bit of increased sclerosis. Okay, you see that calcaneal stress fracture. Get the patient. This is an older patient, and so this patient would have to be non-radiographic. Otherwise, this collapse and get further, and the fracture will extend into the subtalar joint and get more arthritis and get more painful. So pick them up, right? So calcaneal stress fracture, look them up. They're not uncommon. Yeah, just to kind of get you a better view of this fracture. Look the sclerosis. Right? Is this the sclerosis that you see? It's a calcaneal stress fracture. Okay, somebody's asked, is the right mediastinum okay? Here. Sorry, I'm just going back to the old case. It is okay because it's a rotated film. Okay, so when a film is rotated, the SVC, the superior vena cava, can look wider than it needs to. Okay. Let's go back to this. Next, this is the last. Yeah, so this is the next case. Now I can remove bar from the top. Okay, what we got going on? And this is real. So sometimes the patient will have something put on before they have the X-ray done, because the fracture is so displaced, or they've got ankle joint dislocation, that you're not going to wait for them to X-ray the dislocated ankle. So often you will manipulate it, put a back slab, and then X-ray them. A lot of people have got there's something in this. There's a little exactly. Someone's asking for a knee. Why do you want? Okay, so well done for picking this trimalleolar fracture. This is fractured. I think this is also fractured, and then there's I think the back of this is also fractured. But this is a Mason nerve fracture. You know, the proximal. So the force travels up, and it comes out here, right? So they in fact end up fracturing the proximal fibula as well, right? Very good. So that's and unfortunately, you can't get better views. If the patient's in pain, they've got a back slab on, they're not going to move very much. You get limited views. So, but unless you look out for it, you may not see it. I mean, a lot of performers I know in A&E, for especially ankle fractures, they'll have, have you palpated the proximal fibula? But, definitely look out for it. Okay. Okay. This is a fiendish one. I think this is not an easy one. So let's have a look. I'm trying to switch my phone off an iPhone phone now, just in case anybody else can't get in or they can't see what I'm doing. Sometimes some of the colleagues message me. Okay, that's better. Right, come on. This is a good one. Again, real patient comes in. Okay, I'll give you a bit of history. Comes in with hip pain. Right hip pain. People are saying neck of femur fracture. There's no neck of femur fracture, no. Not yet. Right, pubic symphysis, no. Pubic symphysis, okay. Anybody else? Come on. Osteitis, don't worry about that. Leg, no. Left is fine. Left is okay. Okay, let me just help you up a little bit, because in the interest of time, this patient takes bisphosphonates. Yes, bisphosphonate stress fracture there. Look. Very, very important. So Looser zone injury, stress fracture because of bisphosphonates. Similar thing, if you're a female, typically found in really, really sort of athletic females in their 40s, you get stress fracture on the medial side. If you see that, but this is a bisphosphonate-related fracture. If you don't pick it up, this is what happens. They're a nightmare to treat because this region is not very vascular, and therefore it snaps. And so that's next time you see them is this, right? So pick them up. Otherwise, there's a little loosened fracture through it, and then patient gets a nail through it. Okay. This is actually quite an easy one, but I wanted to bring this. There's a teaching point in this, and yes, you've all picked it up nice and easy. There's nothing difficult about that. This is an osteochondral injury at the medial talus, typical location, posteromedial, and in fact, you can see this little dip in the talus. So there's specific locations, specific places you should be looking for in the knee, especially in the femoral condyle, capitellum of the elbow, and talus. Common locations, you'll get them. I mean, it can happen anywhere, but these are common locations. Look out for them. All right, next one. Hip pain. Oh, I did not see the fracture. Oh, sorry. Just quickly see for some. This is the fracture there. Right, this is the fracture. So if somebody couldn't see it, this is the fracture. Because if you don't pick this up, this is what happens. Right, back to this one. Good. I'm glad people are picking this up because it gets missed. This is indeed a left neck of femur fracture. This is a subcapital fracture. You just see the bit of sclerosis around here. Remember, these can be occult. You don't see them very well. And if you suspect it, then get a CT or an MR. MR is obviously better, but again, CT is pretty good as well. And depending on your local protocol and availability, because sometimes MR is more difficult to get hold of because of simply scarcity of the resource. Because if you don't, this is what happens: the patient snaps. So it is People walk past it. That's the reason, and it happens all the time. The left neck of femur fracture, right? Okay. What would you do with this guy? So this is a HBL. You know how they write horizontal beam lateral. What we got going on here? Some of you've got it. This is a naughty radiograph. This is because this is a bipartite patella. Very classical location, bipartite patella, outer lateral quadrant, right? There. There's your bipartite. Look at the edges. Very well calcified, corticated. So superlateral, classical location, right? You can get the bipartite, tripartite, but it's all around about. You might get another fragment there. And when you add the whole thing up, it's usually bigger than a normal patella. That's how you differentiate between a normal patella. So if I draw the outline of this, patella doesn't look like that, right? So patella would be expected to be more like that. So this again tells you this is a bipartite patella. Okay. What's the diagnosis? People are starting to get it. Very good. Ankle fusion. Yes, it is massive ankle fusion. Look at that. Remember, look at the density of this. Right? It looks like soft tissue density. So that tells you normally there's a nice bit of fat here. But if you start seeing the soft tissue density, you're worried. But actually, the fracture's here. Right? Lateral talus. Normally, this should be doing this. Yeah. This is not a. If you miss this and then patient carries on walking, obviously this is an intra-articular fracture. It's disrupted the subtalar joint, so the patient will develop arthritis. Not sure what they can do with this. It's a small fragment. They may pin it or something. Can be seen on AP? No, not really. So that's why you need the lateral. But I can't stress the importance of soft tissue. Right? If you see a great big effusion, look really, really hard, man. Just look really hard. Like how on earth has somebody got a? So this is obviously intra-articular. So that's why it's feeding into the ankle joint. So the subtalar joint obviously has, for many patients, it's linked in with the normal ankle joint. So great big soft tissue swelling, effusion. Look real hard. Look real hard. And if you can't find it, can't explain it, the patient's going to be really tender. You might want to get other imaging like an MRI or something, or a CT. Okay. But also, sometimes you get caught out with little, base of fifth fractures. Okay. Fine. I think a few people are starting to get it. Yeah, good. Very good. Very good. So this is another calcaneal stress fracture, which is will have an intra-articular component to it because obviously it extends into, again, similar patient cohort, older patients, postmenopausal, and they'll come in. They'll have a trivial fall, not very big, just like a neck of femur. Small trauma causes neck of femur fractures. Same with this. You'd need to really look here. And older people necessarily this may not be as painful, so you might dismiss it because stress fractures, yes, they can be painful, but older patients sometimes the pain threshold can be confusing. So unless you look for it, you won't see it. Now this is not an easy one, and this is just so that you guys pay attention to this area. Let's have a look. People are, I think people are starting to get it. Very good, very good. Right, the fracture is here. Okay, there. This is another case of a, what's the name for this fracture? Stress fracture. This is another stress fracture. Why am I showing you a whole lot of stress fractures? Because they do not present with significant trauma. This is another second beta second metatarsal stress fracture. You know, patient has significant injury, you will be looking really hard and you'll get some good, but these patients have small trivial injury, and so you may not necessarily be looking there. And you may, so that's the reason. In fact, this is a stress fractures of second and third. There's a little loosened lesion here, line here. I mean, if you know it, once you know it, then you can see it. If you zoom into the image, but if you don't look out for this, especially older patients, look out for stress fractures. This is not Lisfranc. Frank. Yes, again, a lot of you are picking this up. And in fact, this was actually with trauma. This was with quite a bit of trauma, twisting foot injury. I'll answer that question. How do you know it's not Lisfranc? Okay. So firstly, there's a fracture here. There's a fracture maybe there as well. Okay. So well done for firstly the mechanism of injury. So this is a twisting injury with quite a bit of injury. So the history helps, and they dynamically tested this, and this patient needed a. So this is where the Lisfranc ligament actually goes. I mean, if I go to this, yeah, okay. So the Lisfranc ligament has got three major components. Right? The interosseous is the strongest component. So if you were to look at it on an axial view, so if you were to do an axial through this, you'd see this is the second metatarsal, and this is the middle cuneiform. And so you've got the kind of the more superficial bit, which is quite weak, and you've got a more deeper bit, which is also, and that deeper bit actually goes into some of the other metatarsals. But the interosseous bit is the strongest bit, and that's what we call the Lisfranc proper, and that's the main one. So that's what goes from here to there, right? The deep one. And in this case, the stress fracture has gone through there. So this is actually stable. So this hasn't moved. These two are okay. The fracture is actually from there. If this is disrupted, then you get different types of Lisfranc. So you can get divergent. So this goes this way and this goes that way, or the whole thing goes this way, or actually goes up. So it goes dorsally. And the more displacement, the worse it is. And in this case, the fracture actually is a lot worse than you see on the plain film. And you can see it looks a little bit more, it looks almost crushed here. It's not a nice straight line, and actually extended into the Lisfranc ligament. And therefore, when patient couldn't weight bear, and when you do a weight bearing image, it's splayed out. And so that's why it was unstable. Patient had surgery, and so you can see they've tried to recreate what the Lisfranc ligament would have done. Okay. So that brings us to the end of a kind of a quick overview of some interesting cases, I think, which people overlook. Everybody knows, look after the scaphoid fracture. You will look really hard at it. If you don't see it, you will bring the patient back, and you'll all pick up the malleolar fractures and everything. So I think these are some interesting ones to look out for. If you've got hours and hours to report one radiograph, you'll pick it up. I think in a normal real life as a radiologist, you've got through 100 radiographs in a session or so. Sometimes, unless you kind of really look out for them, you may end up sort of missing them. And if you're ever worried about something, repeat the scan, bring the patient back, or do other sort of imaging, MR, CT, whatever. Right. Some important thing: do not log out yet. I can see how many of you logged in. Right. So top tips. top tips from an MSK radiologist on this stuff. Soft tissue, I can't stress the importance. A really senior radiologist when I was training, MSK radiologist, she would really home in, soft tissue, really important. Yes, soft tissues aren't amazing with CT, with plain film. Actually, you get good enough information to raise your alarm bells. Okay, satisfaction research. Just because the likelihood of having a second fracture or a second abnormality is higher with a single fracture. Practice, follow up if you're not sure. And also the other thing is from learning point of view, well, I remember when I used to work in A&E, or you diagnose something, but then the patient, or even as a radiologist, you diagnose something and it just goes away. You have no idea what you said is correct or to what level. So I would, keep a record of those patients. In a couple of weeks' time, go back if they had an MRI, if they had a CT, look at the follow-up letters. What was the management for it? So this will make you a better clinician, better radiologist, better practitioner, radiographer, because your report will be much more. It's not just, oh, there's a fracture. I mean, not most people I've seen, and then maybe, I'm not going to argue about that. No fracture, but actually you'll be able to advise a bit more in your report. You have a much more sensible report, and the other thing, you can't stress the importance of reading and having good trainers, because you can have, you can be reporting for ages and ages and ages and have bad habits, and those habits just stay with you forever. And so you may be safe, but not necessarily good. And so that's really important. Right. So if you want to give feedback, feedback is really important. Is if you can visit this website, feedback.radiologyseminars.co.uk. It's just a little simple form. It'll take you 10 seconds to just fill it out. It'll be really helpful. You'll get an email of a CPD credit as well. Oh, then do not miss this next month on the 17th of February on Wednesday, 6 p.m. Dr. Ram. Oh my God, he's a really good radiologist. I worked with him in Stanmore. He's doing a very good session on bone tumor mimics on plain film. So these are radiographs, and so everybody who's here needs to attend this one, because lots of stuff you'll see. Hang on a minute, is that a tumor? Is that something abnormal? And the reason Ram is really good is because he's written a chapter on this entire topic in Granger and Allison, the new edition of Granger Allison. He's written the chapter on this particular whole topic. He's going to summarize it for us next month. On the 17th of Feb, do not miss it. He's a very good speaker, and and he's a very good friend. So, and he's at the best, orthopedic hospital in the world, I think, in Royal National Orthopedic Hospital. I'm biased, and so do not miss it next month. And obviously, some of you've asked us, and many of you've already signed up to this, is the emergency X-ray course. The whole day is dedicated to trauma and emergency X-rays. There's only so much I can cover now, but I hope you enjoyed it. The next session, that's the next session, somebody's asked. I hope you enjoyed it, and take care. And